Well, joining us up first on the show, we are talking about prostate cancer awareness, and we are joined by a local doctor. It's Dr. James Sanders. So I want to thank you so much for coming in today.
Hello, thank you for having me.
Thank you. Now, tell us a little bit about what initially prostate cancer is and kind of who it affects.
So prostate cancer affects men. It is the most common internal tumor affecting U.S. males. About 1 in 9 men can get prostate cancer, and it's a cancer that doesn't necessarily present with symptoms. So the controversy surrounding prostate cancer is how to diagnose it, whether or not to get screened with a PSA test.
And definitely that's something that you know, doctors do recommend, is to go ahead and get tested to see if there are any signs.
Yes, in 2012 there was a U.S. Preventative Services Task Force that looked into the data of PSA screening, which we've had PSA screening now for many years, decades, and they actually looked at some new data and recommended against PSA screening. So that was 2012. That panel did not have any urologists or oncologists on it, and the urologist disagreed, and then a group of urologists in 2013 then came out with a statement. They kind of looked back at that data and saw that there was good evidence from that data that there was a mortality prevention benefit to PSA screening.
And if one were to not get these screenings, are there any symptoms or signs that they would be looking out for initially, or is it just because they are getting these screenings, that's kind of how they find out?
So clinically localized prostate cancer will be asymptomatic or without symptoms. It doesn't present with symptoms until it's advanced or outside of the prostate. And those symptoms could be bone pain, especially in the back, or perhaps some urinary voiding symptoms or blood in the urine, perhaps.
And say, you know, a patient gets diagnosed and they find out that they do have prostate cancer. Is it something that, kind of what is the process moving forward then with a doctor? So first, general screening tests are done with your primary care physician, and then if you have an elevated PSA, then they send you to talk to your urologist, and from there you sit down with your urologist and decide whether you look at prostate cancer risk based on your PSA results. And we have web-based prostate cancer risk calculators now that I'll sit down and go through, put in the patient's individual data, and have a conversation about what their prostate cancer risk is and whether to go forth with a prostate biopsy. And then from the biopsy, you get back pathology results that say whether you have cancer or not, whether it's low grade or high grade, and then we have a kind of a risk assessment discussion about treatment and whether to go through with treatment or what kinds of treatment. And is there a certain age, or is there a certain time in a male's life that they should be going and getting checked out by their doctor?
Yeah, kind of the median age of men getting prostate cancer is 65, but it can affect men prior to that age. As far as when to start screening, the AUA recommends from 55 to 69 is a time to discuss with your doctor to get screened or not get screened. The PSA screening trials I talked about, one of the good studies out of Gothenburg, Sweden, screened men from 50 to 69 years old, and showed in that cohort there was data that PSA screening reduced mortality.
And say someone, their grandfather runs in their family, or somebody, not necessarily runs in their family, but somebody was affected by it, maybe their father or grandfather. Is it something that a younger generation male should be taking into consideration as far as going to getting screened sooner or talking to their doctor sooner about it?
Yes, if you have family history is a risk factor for prostate cancer. So especially if it's your father or grandfather. If you have a family history of prostate cancer, they do recommend getting screened earlier, talking to your doctor at around the age of 45. In general, without family history, with looking at 50 or 55 to talk to your doctor about it. But yes, there is a higher risk in men who have a family history of prostate cancer.
Right, and so of course you're recommending that people go in. I mean, a lot of the time people are afraid to go to the doctor and to ask questions and to kind of find out, okay, they'd rather, I don't really want to know if something's wrong, because if I don't know, then it's not really happening. But as you mentioned, you kind of recommend going and doing these PSA screenings early on to kind of, or when they're supposed to kind of find out, all right, what is my status? Am I okay? Am I not? Kind of, and then being able to attack it and move further on.
It's always better to know because it gives you a chance to perhaps treat the prostate cancer before it's outside the prostate.
Right.
Treatment of prostate cancer is, there's a big difference when it's localized within the prostate. Cure is achievable. When it's outside the prostate, cure is difficult. And you're more taking treatments to manage the cancer as opposed to cure it once it has spread outside the prostate. And like I said, there's no symptoms when it's clinically localized, so the PSA screening is the only way you would know.
Right.
And the PSA test doesn't tell you whether you have cancer or not. It's just a risk assessment.
Right.
And then if you have elevated risk, it's a chance to talk to your urologist about it or your family doctor. And the concern with the U.S. Preventative Services Task Force in 2012 was that the risks of treatment outweighed benefits. But at least the PSA gives men a chance to have a conversation about those risks.
Right.
And if you find out you have low-grade prostate cancer, you don't necessarily have to undergo surgery or radiation. If it's a small amount of low-grade cancer, some men undergo active surveillance, where we will watch the cancer, watch the PSA, repeat biopsies, and can forego surgery for years. And then if things change, then they can proceed to surgery.
Right.
But it's a chance to have that conversation with your doctor.
Most definitely. All right. Well, I want to thank you so much for coming in today and kind of chatting with us a little bit about this and offering some insight and offering some information. So thank you so much for coming in.
Yeah, you're welcome. Great to be here.
Thank you so much.